our lives. Great, thanks. All right, let's get back to it, Nolan.
All right. So this is to kind of go back to insured versus self-insured without getting into the details of ERISA, because that's a rabbit hole that I don't want to get into without my lawyer present. But just basic difference between what a self-insured plan might be able to do versus a regular insured plan. So in a regular insured plan, the insurer bears the risk or most of the risk. So it might be you hire, you're a large company and you decide that you, rather than bear the risk, you want to hire what's known as a third-party administrator, and you might buy a plan through Blue Cross Blue Shield. Oh, sorry, that's self-insured.
Yeah.
Regular insured would be like, I'm an employer, I'm just going to go on the market and I'm going to buy plans for my employees. Where self-insured is an employer would assume all of the risk or most of the risk. And that might be saying, okay, well, we're going to hire a third-party administrator, like Blue Cross Blue Shield has those kind of plans, and these are the benefits that I'll have. But basically, the company is basically covering those costs, because in their theory, they might say, well, you know what? We think that covering the costs might be more cost benefit in that for our company than just paying a premium. And this is why you see a lot of large companies have a lot of these employee wellness plans. They say, well, we're going to encourage our people to be healthier. We're going to encourage our people to walk more or whatever. And so it's a business decision in those companies. But the big difference is the insurer assumes the risk versus the company. So the employer purchases a coverage from a regulated health company, an insured plan, where, as I said, the self-insured plan, they might hire administrative services of a third-party administrator. And then finally, and then I'll answer Representative Golden's question, an insured, again, the insurer is subject to state regulations, but in her self-insured plan, they're not subject to state regulations. So
I was just wondering if you talk more about risk. It took me a long time to understand what that meant when you say the employer assumes the risk or the insurer bears the risk. What's the risk?
The risk is of having claims, of financial risk.
The risk is you have a population of people, and the risk is every sick person you have to pay for.
Yeah, it's the financial risk.
That's a hard one, I think, just to get around. So pointing that out.
Can you just clarify for us whether or not, I think our two biggest groups are state employees and teachers. They're self-insured.
Yes, no.
Yeah.
So the state of Vermont are self-insured, but we're public self-insured. And so we actually have even different rules. I didn't want to get too much into it because that goes down another rabbit hole. So we are, I don't know that it's under ERISA or it's a different subtitle or something other. So in short, we are self-insured, but a different self-insured than others. The teachers are actually all under small group now or something, because what they've done is they used to have their own plan, but several years ago they started buying plans through, I think it's Blue Cross Blue Shield. So they're not, there used to be a thing called association plans, and they come, they go, they come, they go. It's a whole other rabbit hole. But in short, teachers are not self-insured.
But do the decisions we make here affect teachers or state employees?
Yes. If they're small group plans that they're purchasing, we would regulate them. If they're large group plans, we would regulate them. If we institute a mandate, their plans cover them. That's my understanding. If I'm wrong, I'll get an email.
I was going to say,
I think the answer
I need some clarification on that.
There used to be associations which had a different piece which was regulated, and now they're a different animal.
Yeah. All right, we'll come back to that.
Yeah, Lori, with that, Alyssa brings up something we ought to know about. I think we ought to really know about these. I don't know if anybody else getting emails, but I am. Okay, we really do need to know about that whole thing. I would like to. Anyway.
You're talking about the teachers moving to teachers and retirees moving to a Medicare Advantage. So that is a question. A state. No. teachers or state employees, you're right, state employees.
Yeah.
That is something that is being determined what the legislative role might be in that. So I think that's a separate
Yeah,
animal.
oh yeah, it's not for
We
today.
need to make sure we understand about teachers.
So the teachers have changed their plan, right? Or the state has changed
The retiree.
the retirees, okay.
Well, yeah, I won't even get into that. I don't know enough about it to sit up here and.
Well, I'm getting emails on that too, and now it's the
Okay.
state employees, so.
Right, we can,
hasn't changed.
it hasn't changed yet. Right. All right, we'll table that conversation and come back to it.
And that tends to fall under contract negotiations, the teachers'
Right.
plans, so that's. Gosh, stop stumping me. I'm supposed to come up here and look like I know what I'm talking about. You guys are putting chinks in my armor. I'm just kidding. Just kidding. So we're going to talk about the private insurance. Approximately half of Vermonters have private insurance. And again, most of those plans are employer-sponsored insurance. We often call them ESI. You hear a thing called COBRA, which is, if you lose your, well, there's just different federal law, but when people think about COBRA, they think about I lost my job or I quit my job, but I want to stay on my insurance. I'm paying, I can buy into my own insurance through COBRA. And that's we don't really talk a lot about COBRA, and it's a very small number and it's temporary. Approximately 3/4 of employer-sponsored plans are self-insured plans. So that's what I'm sort of flagging here. Of those ESI plans, of this square over here, 74% are self-insured. Vermont Health Connect, and you will probably hear a lot about this. You'll probably get reports. This is when you hear about a thing called the Health Benefits Exchange. Vermont Health Connect is Vermont's health benefit exchange. This was established under the Affordable Care Act, or the ACA. It's an online marketplace for individuals and small businesses to purchase their health insurance plans. And if you're an individual, we'll get into more, the individuals may be eligible for subsidies. And we'll get more into that down the road. It's administered by the Department of Vermont Health Access. And you'll hear about from AHS, but Department of Vermont Health Access is part of the Agency of Human Services in Vermont. So when we talk about Medicaid, it's DEVA. DEVA administers our Medicaid. So if we go, I got to talk to Medicaid, I'm referring to DEVA. So I just I like this slide because, again, I'm telling the story. So we have our small employers defined as up to 100 employees. There's approximately 40,390 people covered by small group plans. Individual plans, which are on the right side, there's approximately 30,364 people who are covered by individual plans. 3/4 of folks on those plans are receiving some kind of financial assistance from either the state or the federal government. For the feds, it's federal advanced premium tax credits, often referred to as APTC. And that's available for those up to 400% of federal poverty level. So stop here for a second. If you go to the last slide, or on the wall over there is an FPL chart. So when I say 400% of federal poverty or 250% of federal poverty, you want to know what that translates to? The last slide on the back page has an updated FPL chart, which may update again for 23. It may not. It might stay the same. So, but that gives you a sense of what size household income equals each of those FPL levels. So the federal government has federal subsidies up to 400%. We also have state subsidies up to 300%. Why 300%? Well, there's some history there because previously, prior to the Affordable Care Act, we had a program called Catamount Health, and we offered subsidies up to 300% of federal poverty. So when the Affordable Care Act came in, Catamount had to go away, but we were able to convince the Fed to allow us to get federal matching dollars for folks up to 300% of federal poverty. That's why we go up to 300. They wouldn't let us do 400. So for folks who are not receiving financial assistance, they can buy directly through the carriers, or they can buy through Vermont Health Care. But if you are a higher income person if you're a person below 400% of federal poverty, you want to buy through the exchange because you'll get something from the federal government in the subsidy. if you're over 400%, you might be better off buying off the exchange because it gets into this whole nuance of some things we've done called silver loading, and I won't get into it, but anyway, you can buy either on the exchange or off the exchange. And again, this is just meant to tell the story of how many people are in each group.
Just a couple clarifying things. One, I misspoke earlier. So when you buy off the exchange, the carriers, as Nolan said, are Blue Cross Blue Shield or MVP. It is not Cigna. So that was my mistake. So I want to just clarify what we mean by carriers, and that's Blue Cross Blue Shield and MVP. There are insurance companies here in Vermont.
Yeah, and there are folk who have Cigna, but that's usually an employer plan. But the two big ones in Vermont are Blue Cross Blue Shield and MVP.
So wait, before you go on, because I was wondering if you're going to do this. So I want to be clear again about what population our decisions really affect. So if we add up small group and individual, how many?
It's like 70-something thousand.
About 70-something thousand people are one group of population that our decisions we have an impact on them. And then Medicaid is the other group, which is about 23% of 24% of our.
Talking up to 150,000 people or so.
So about
And in a large group, which is not a very big.
not a very big number. So just want to point that out. Thanks.
What's the Medicaid number again?
Oh, I'll get to that. I'll actually have a slide.
Okay, great.
So real quick, military, there's 16,600 folks that have military. We don't have any regulatory controls over them, but their group, I wanted to just mention them.
One thing on the military people, they use TRICARE as their coverage administrator.
I've never, I don't deal with that kind of,
Okay.
so I don't know, I know there's TRICARE, and then there's folks who are active or deployed, and I don't know.
The only reason I ask is I was approached by someone this past summer that said that TRICARE isn't accepted in very many places, and that's the care used for military people. And it's not anything to do with what we're doing here today, but it's something that came to mind.
It's not just tracking.
Then we have the uninsured. Obviously, as a group, we wouldn't say we regulate them because they're not any group. What I was trying to show here is not only showing how our uninsured rate dropped since 2012, but also just to give you a sense, and this is there's a thing called the Vermont Household Health Insurance Survey. I encourage people, if they have time, to look at that. I can send folks the link. But according to the survey,
You can send it to me. Thank you for a reminder.
But the story I want to tell with this slide is that of those who are uninsured, 20% of those folks are eligible for Medicaid. So then you get to the question of, well, why are they not on Medicaid? Well, there's various reasons, but I just want the flag that a lot of people who are uninsured are eligible for a program. They're just not on Medicaid. And it may be they don't use any services. It might be that they don't know they're eligible. Usually what happens if you're uninsured and you go to the hospital, they will ask you if you were signed up, because hospitals want to get paid. And they'll do everything they can to help sign you up. And you can be signed up retroactive for Medicaid as well. So nonetheless, there are 20% of folks who are not eligible for Medicaid. There's some folks who just don't want to be on it. They just feel like, look, I don't want whatever, the stigma or whatever. I just don't want to be on Medicaid. Yes.
Sorry, I want to go back to Art's question. I don't know if everybody heard his question about TRICARE or what coverage veterans have for insurance. Would they be on Medicare or is it TRICARE?
It's their own.
It's the 65.
At 65, they might be able to be on.
The military has their own insurance. It's just called TRICARE.
It is TRICARE?
Yeah.
Okay. So they would be on that before Medicare or Medicaid?
It's private insurance. It's considered private insurance. And so if they have TRICARE, then not on Medicaid unless, I mean, there's some things that have to do with your income and if you can't make premium, there's whole other rules. But in short, I guess it depends on the various situations. If you are eligible for TRICARE, but you're very low income, you could probably still be on Medicaid.
But Medicaid's always the last payer, right?
Last resort.
Yes. So if they can have TRICARE, I'm going to step back and say I can't answer your question.
Right.
I'm not an administrator or an eligibility specialist.
Right.
So
And TRICARE is not something that comes before this committee.
Yeah.
Okay.
Yeah.
No, you'll never see it. It's just something that came to me from a soldier.
Okay.
So it's a good question, but I don't want to act like I know the answer when I don't.
Okay.
We don't deal with TRICARE.
So we can, suicide prevention stuff does come before this committee, and I know veterans and suicide is an issue that
Yes.
touches many of our constituents. That's
That might not be paid for TRICARE. That might be paid for with other programs,
okay.
federal programs that grants and other programs to try to.
Right.
So that wouldn't necessarily be TRICARE.
No.
Got it.
So again, 20% were eligible for Medicaid. 52% of uninsured were eligible for some kind of state or federal subsidy. And then 33% of folks who are uninsured actually had access to employer-sponsored insurance. Then the survey asked them, well, why aren't you insured? And 51% cite primary reason that as cost is the reason they didn't have insurance because it was unaffordable. So I'll talk a little bit about COVID here. Of those who are unemployed or furloughed due to COVID-19, 84% maintained their coverage. So we did see that during the pandemic that when a lot of times when people got laid off, their employers continued to cover them, or they were furloughed, or they were able to get picked up by Medicaid. So we didn't see a large spike in the uninsured rate. Yes, some people lost their insurance, but we saw that of those who were unemployed or furloughed, 84 still maintained some form of coverage. And you can see here different ways that they were covered. And this is just a slide from the Vermont Household Health Insurance Survey. Some were able to enroll in Medicaid. When it says or Green Mountain Care, that's basically Medicaid. It says Green Mountain Care. That's another nuance I'll get into in a minute of Green Mountain Care versus Medicaid. Other folks still had insurance even though they got laid off. They still maintained insurance to their spouse, or they had COBRA, or they wound up purchasing through Health Connect and were able to get subsidies, et cetera. So I put this slide in because I felt like it was relevant to the current situation. Again, just kind of helping tell the story of what different Vermonters experiences. The story I'm trying to tell with this slide is, so this on the left, it's the same chart. You can see that 24% of folks were on Medicaid across the whole population. We talked about Vermont having a low uninsured rate. Well, for kids, only 1% of kids were uninsured in Vermont. We had 3% uninsured rate for everybody, but it's lower for kids. It's about 1,200 kids. But whereas 24% of the population are on Medicaid, 52% of kids, those under 17, were on Medicaid. So that's the story I want to just sort of show that we have a high Medicaid population or for coverage for kids. So I want to, all of us, including myself, sometimes say Medicare, I mean Medicaid, you know, the words are so close to each other, but they are very, very, very different. And they are not the same. So that's what this slide is really trying to help you understand. So Medicaid is a state and federal program. We have control over that. Medicare is a federal program. We have no say. To be eligible for Medicaid, you have to be low income. In Medicare, you just have to be 65 or older. There's no age limits. In Medicaid, you have to be 65 or older, blind, and disabled. In Medicare, you have to be 65. You can be any age or have end-stage renal disease. Or if you're under 65, if you have some kind of disability, you're eligible for Medicare. So,
From someone who has an adult brain, Medicare has an E at the end, elderly.
Oh, good. Thanks, Leslie. All right.
I know it's, you may not have access to numbers on this, but the the report that you referenced, the Household Health Insurance Survey, does talk about underinsured, which
Yes.
I don't want to forget about, because that's
Yes.
one of the biggest problems we have. It's not enough to just have to be covered by a health insurance plan. It may not be affordable to get care.
Correct. And I don't believe I addressed that in this presentation. Can't remember, but I have done presentations to this committee in the past about, there's a universal definition that has sort of people, I forget which company or which
Commonwealth
does it, but it has to do with the percentage of your income relative to something or other. So there are some nationally sort of, there's no real definition of underinsured, but there's sort of definitions that everybody sort of says, well, this is going to be our threshold that we use to define it.
And does everyone understand the word underinsured? People who have insurance, but it's too expensive for them to actually access it.
Deductibles, co-pays.
Exactly.
premiums.
So Medicare is a federal program. We have roughly 120 to 130% of, or 21% of Vermonters are on it. Most of those folks are over 65. But we do have about 1,500 or so kids who are under 17. Again, that's because they have the disability eligibility. Anyone with end-stage renal disease, it's a carve-out. I couldn't tell you why it's carved out. And then there's some parts, because you have your A, your C, your D. Oh, do you
Carve out, can you define that?
I should have said that term. Well, carve-out actually isn't the right term for this particular piece, but a carve-out would be like, the rules apply to everyone but this group because for a specific reason or in law, so that might be the carve-out. Like, you are subject to a particular law unless you meet A, B, or C criteria. So carve-out is really a generic term, and I probably didn't use it correctly, but good question. And then we have what's known as our Medicare A, B, C, and D. Each of those have different requirements. So Part A is primarily hospital and inpatient care. B is most other services. You'll hear about C, which is Medicare Advantage plans. And I'm not going to go into that. And I don't know how much we do in this group. And you have Part D, which is your pharmacy coverage.
Can we comment on that? Mm-hmm. Some of you brought up that your constituents were being in touch with you about that. And we actually passed a bill last session about that. And there's a report coming out January 15th, which will come to our committee.
About Medicare Advantage.
Medicare Advantage plans. So that could be a response to your constituents, saying we hear it, we know there's a problem, the legislature's studying it, and we're getting a report mid-January, just so you know.
Although I do want to be clear, we're not studying the issue with what's before the State Employees Association. So that's separate from the legislation Leslie's talking about. Okay.
So Medicaid. So this is we're getting into the meat of things that we will do and things that you do have some influence over and we'll be hearing about and we'll be voting on. So Medicare at a high level, it was created in 1965 as part of the Social Security Act. It's a public health benefit program for low-income individuals and families and individuals with disability. It's financed through a federal-state partnership, which is administered by the states, and I'll get into more detail about what that means. And then each state designs and operates its own program within a broad federal guideline. And the kind of funny, not funny joke is sort of the Medicaid directors and other folks in this say is, if you see one Medicaid program, well, then you've seen one Medicaid program, because every state Medicaid program is different. And I will talk more about that. And then later in the week, we're going to be talking about something known as global commitment. And that will get more into the weeds. And then you'll start to see what I mean by, if you've seen one Medicaid program, you've seen one Medicaid program. But real quickly, global commitment is the name of the agreement with the feds that we use to administer our Medicaid majority of our Medicaid program. And again, I'll have some charts showing you how much is under global commitment versus everything else. But the term you're going to get very familiar with. You're going to hear about it when we get the budget and you hear BAA. Global commitment is a big part of that. So before, when I had the other chart where it said, Green Mountain Care, Vermont Medicaid is administered through DEVA, but they call it, the umbrella is called Green Mountain Care. If you're on Medicaid, just like I'm on Blue Cross Blue Shield, I get a card that says Blue Cross Blue Shield. If you're on Medicaid, you get a card that looks like this and it says Green Mountain Care. It's just a name that they've given their insurance product. There's different programs under Medicaid. You'll hear about Dr. Dinosaur, you'll hear about this, you'll hear about that. Green Mountain Care is just like the umbrella. It's like saying Blue Cross Blue Shield. It's like saying Medicaid. That's just the name of the card. What makes it even more confusing is for folks who were here 10 years ago, when we're talking about single payer, the name of the single payer was going to be called Green Mountain Care. I don't have to keep this little star in there as much now, because as we move farther and farther away, less and less people are associating it. I know Ellen is here, so she will definitely be thinking about Green Mountain Care. But it's still something I flag. So nationwide, so these are the numbers, Representative Adriana, that we were talking about. So nationwide, we have about 90 million folks who have coverage through Medicaid or CHIP. CHIP is what's known as the Children's Health Insurance Program. CHIP is actually separate from Medicaid, but in Vermont, we administer CHIP as part of our Medicaid program, so we still kind of consider it as Medicaid, but it's a little bit different.
So is CHIP the same as Dr. Dinosaur?
CHIP is part of Dr. Dinosaur. Dr. Dinosaur is basically our kids. Any kid, so those 0 to 17 who are Medicaid, we call it Dr. Dinosaur. But under that, it might be different programs that administer, but as far as they're concerned, it's Dr. Dinosaur. So now there's another nuance that I would like to emphasize. We have about 208,000 people who have some form of assistance through Medicaid or CHIP, or we'll say Medicaid, including CHIP. So we have those who have primary coverage, and that's approximately 163,000. So that would be Medicaid is their primary. I go to the doctor, Medicaid's paying for it. And then we have another 45,000 that have a supplemental. Now, what does that mean? So we have our premium assistance program, for instance, through Vermont Health Connect. I make too much to be on Medicaid, but I make enough or too low to the point where I can still get some subsidy from the state. That's paid for through the Medicaid program. So Medicaid is supplementing my private insurance plan. So those folks are not on Medicaid. They just have a relation, their insurance has a relationship with Medicaid is helping. So I throw this out because you'll hear on the news, oh, well, 1/4 of Vermonters are on Medicaid. And that's not technically true. Or no, 1/4 of Vermonters is technically true. 1/3 of Vermonters is not technically true. 1/3 of Vermonters have a relationship, whether it's primary or secondary, and a quarter of Vermont. So if someone says 25% of Vermonters are on Medicaid, well, that is true. We're really 24%. So that's a nuance that I really like to. So when I see in Digger or other stuff, sometimes or in CAX, not calling them out or pointing fingers, but sometimes in the media they may say that, and it's like I cringe because I'm like you. I like in the weeds, like, well, that's not really, but we know what they meant. But I'm a numbers guy, so. In Medicaid, we think about who's covered and what's covered, right? And I'm not going to get too deep into the eligibility wormhole, but in sense, in order to qualify, you have to be a Vermont resident. You have to be a U.S. citizen, permanent resident, or a non-citizen with lawful presence. And I'm looking over Representative Cordes because we had this conversation several years ago about how to correctly term these things.
Thank you.
And then we have financial situation, which would characterize them as low income or very low income, such as if they're pregnant, they're responsible for 18-year-old or younger, we'd call them, potentially call them a caregiver of support. If they're blind, have a disability or caretaker of someone with a disability, or to 65 years of age or older. So those would folks who would fall under it because of financial situation. And then we have our benefits. So we have the who is covered and we have what is covered. And under Medicaid, states are required to cover mandatory benefits, and then they have things that are optional. So what this is showing you is under federal law, the left side, the mandatory, those are things that if we have a Medicaid program, which every state does, we have to cover those. And then we have our optional services. These are things we don't have to cover, but we may cover them. So for instance, a lot of these Medicaid does cover dental, other stuff. And then you have things like Chiro, which we cover, then we didn't cover, then we did cover, then we didn't cover. And so a lot of times in the past conversations, folks have been like, I want to find some fiscal relief within the Medicaid budget. Are there any services that we can eliminate? And the answer is most of the money is in the mandatory services. So, we want to cut one of these things. You don't save a lot of money. But to give you a sense of like areas that we can control, so we can add things that aren't on this list. And I don't have a list in front of me of which of these are of the optionals we do cover versus not cover. But that's an example of a piece of the Medicaid program that we have an influence over.
Is there a list somewhere that would allow us to see what of the optional services Vermont does cover?
Yes.
Great.
I don't have it, but we can get it.
Thank you.
Process question. So some of us ask for things. Is it something that might go to everyone just because, I'm interested in that, that kind of thing? So
I would say if it gets sent to just you, then please feel free to send it out. If it gets sent to Claire, she would send it out to everyone. Nolan may remember that you requested it or Joe, so he'll send it appropriately and feel free.
Yeah, that's what I'm wondering. If this goes to Claire, then he doesn't have to remember anything.
There hasn't generally been a fixed way. What I'll say is like some agencies and departments, when they come in, they'll write down the questions, then they'll email Claire, here's the question, here's the answer, and then Claire will send it to everybody else. In my case, sometimes someone's asked me something and I might send it to Claire. For other times I might be like, I'll just send it directly to you because I got the sense that really only you wanted to know. Whereas other things like, everyone wants to know. So there's a little bit of discretion there. Unless you come up with a policy, that's your call.
I would like to leave it up to the discussion of the person that's sending the information.
Sure.
Great. But again, amongst us, feel free to.
Gotcha. So global commitment, I'm going to give you an hour of global commitment later in the week. So
Get ready.
But just very high level. And I also subscribe to the idea that you can never hear this stuff too much. Repetition. So this is your first high level swipe at what global commitment is. Global commitment is actually known as global commitment to health. We call it global commitment for short. It's the name of the agreement between Vermont and CMS, which stands for the Center for Medicare and Medicaid Services. They are the federal agency that oversees Medicare and Medicaid. They're the ones who we negotiate with for our Medicaid program. They're our federal partner in Medicaid. So it's an agreement between Vermont and CMS that is used to administer the majority of the program. I say the majority because there's a small number that it doesn't regulate. It's what's known as an 1115 demonstration project. That's a technical name, often referred to as a waiver. We will usually just say, so a lot of times we'll say the waiver, or we'll say global commitment. We use those terms interchangeably. But global commitment is our 1115 waiver. And what that does is that allows us to waive certain provisions of Medicaid law that give state the flexibility to encourage state innovation in designing state Medicaid programs. So basically what that means is that, federal law says, you have a Medicaid program, this is what it looks like. But what 1115 waivers were designed to do is to encourage states to promote innovation, to say, if you can come up with a way to augment your program in a way that meets the needs of your population better, doesn't cost the federal government any more than it would have cost in the absence of the waiver, and still meets all these criteria for which we require in terms of who's covered and who's eligible and all this other stuff, go for it. But there's this whole, it's not that easy. Negotiating takes years. It takes months. The whole process might take as much as 2 years to negotiate. But in short, it must be budget neutral. They generally reflect the priorities of the state and the priorities and the goals of a specific state. And last time I looked, at least 40 states had at least one approved or pending 1115 waiver. Again, this is when I said, if you've seen one Medicaid program, you've seen one Medicaid program. If you have 40 states that have waivers, each of those waivers is tailored to that state, depending on the priorities of those state leaders, of what the population needs. their budget priorities, their particular health issues, et cetera, et cetera. The vast majority of our $1.9 billion Medicaid program is administered through Global Commitment. It has enabled the state to implement many programs that would not have received federal dollars in the absence of the waiver. So in short, if we did not have our waiver, there are a lot of programs we currently have that we would have to pay 100% state dollars for to cover the programs where currently we're paying only a percentage of that we're paying, and now get into federal matching. So that's the benefit of Global Commitment. And again, I will get deeper into the weeds on this later in the week. Dual eligibles, just a quick note. Again, Medicare is the payer of first resort. When you saw the previous slide and I had the pie charts and Medicare and Medicaid and 24% and 21%, if they're dual eligible, I'm counting them as Medicare. That's the bucket that they fall into. Again, that gets into the primary versus secondary. They'd be a secondary on the Medicaid, primary for the Medicare. That's about 18,000 people. And I want to say this number is 2021 number, but basically Vermont, the Agency of Human Services, we spend about $240 million per year on healthcare and other support services for those 18,000 people, just to give you a sense of how expensive it is.
So just to be clear, that those 18,000 are not included on slide 44 of the 45,000 parcels?
They are.
They are.
They'd be under the 45.
They would. Okay.
Not under the 190 or 150 or whatever.
So even though Medicare is paying for all of it?
They're the ones who I say have some form of relationship.
Okay.
When I said premium assistance, I could have put duals under there too. Good question though. Good clarifying. So we're going to get into a little bit of the overall health spending. So in 2020, Vermonters spent $6.4 billion on healthcare. I want to flag then, again, like I said earlier, in 2019, we spent more. It was the first year it went backwards for the first time. Medicaid. So we talked about 24% of folks being on Medicaid, but Medicaid accounts for 27% of expenditures spent on behalf of Vermont residents. So, and this has a state implication because we, as the state, control Medicaid. So now I'm going to start getting into the budget a little bit. This is a 22 number. This shows the operating budget. And you can see the Medicaid. So the blue are the state funds and the orange is the federal funds. But if you were to take the orange and the blue and stack them for both Medicaid and pre-K, you can see Medicaid is it's a little below the amount we spend on pre-K, but Medicaid is the second largest budget item expenditure in our state budget. So this has a huge fiscal implications for our state budget.
So the blue bar on Medicaid is just the state match, and the orange bar is not really our money, it's Fed money that's
Yes.
matched. Okay.
And if you stack them on top of each other, then there'll be the total spend. This chart was for a different purpose. I couldn't find a way to do it otherwise, but I wanted to still tell the story, which is that Medicaid, education is our first largest expense in the state, but Medicaid is a very close second.
But I also think it's important to show that we receive a lot of money from the federal government for
We do.
Medicaid.
But if you look at,
Trying to get at that, yeah.
yeah, but from a budget standpoint, if you look at just the blue, you could still see Medicaid is our second largest expenditure. That we
Absolutely.
spend.
The PK-12, is that ESSER? What is that?
It's education. It's all education spending.
Okay.
This is a total spend.
Nolan, what does other government mean?
Like before.
Now he's looking at the far, which slide are you on?
Yeah.
I'm looking at 49.
So that would be like, I think that would be like health department. Stuff like that. I can look at there's
So you mean like having shots for nothing?
yeah, or prevention programs that might be through the health department. Those are expenditures that are the government grants that affect healthcare that count as healthcare expenditure but don't fall under a traditional payer. So Medicaid financing. Overall, our Medicaid expenditures are $1.9 billion gross for fiscal year 22. When I say gross, I don't mean, ew. Sorry, if you Representative Tina would like that. I mean, and it's also 3 o'clock. I mean, state and federal. So if it's state, I'll say this is, $10 million state dollars. But if it's gross, I'm talking state and federal combined. Medicaid, as I said, is financed through a combination of both state and federal matching dollars. In fiscal year 22, our federal participation accounted for approximately 70%. This is actually a big jump. Usually we've always said, it's 60-40. We have various matching rates and grants and stuff from different programs. So this is just the total spend. I'm going to get a little bit into how we match things. But generally, our federal matching dollars will range between 50 and 90%, depending on the program or expenditure. Not all of our federal funds are through what is known as FMAP. You're going to hear a lot about FMAP. FMAP stands for Federal Medical Assistance Percentage. So FMAP is basically the state share, or the state Medicaid is the share of state Medicaid benefits costs paid by the federal government. That's why it's federal match, FMAP. It's calculated by the federal government. It's a 3-year average of state per capita personal income compared to the national average. And no state can receive less than 50% or more than 83% of our FMAP. And this is just to give you a sense of what other states are paying. The big states that have, Connecticut, Massachusetts, New Jersey, those kind of states often will have, they're at 50%, and they won't have to pay more than 50% of their FMAP. It changes every year, and I'll show you in a slide. And I won't jump ahead of myself. The little arrow just shows whether it went up or decreased from the previous year. In addition to the FMAP, we are also currently receiving 6.2% additional FMAP as part of the Federal Families First Corona Response Act. 6.2% translates to about $22 million per quarter, or roughly $45 million a year. So when states were struggling, when the coronavirus hit and states were struggling, the feds put in this as part of relief for states. They put in the 6.2% additional on top of our base FMAP, which I'll get into more detail, for as long as there is a public health emergency. And so we are currently continue to have this public health emergency. So we're continuing to get that. It's been a huge help, which means in short, when we're getting that much more federal dollars, is that it frees up that much general fund or that much less general fund that we're having to spend. We also have FMAP for expansion populations, which I'll get into in a second, but I want to also talk about FMAP being a double-edged sword. So for here, we have different FMAPs. So most of our programs are regular FMAP, and you can see that's the top one. So the rate for 24 is, for every dollar, it's 56.52% is federal, 43.48 is state. Again, this is a calculation based on a 3-year average per capita relative to other states. So in short, every dollar we spend using the regular FMAP, we get $2.30 total gross. So the flip side is that when we cut a program, we are losing, for every dollar we cut, we're losing $2.30 in program. So we put $1 in, we're getting $2.30 towards the program. If we cut that dollar, it cuts deep. So it cuts deep both ways. Our FMAP, we have different programs. Most of it's under the FMAP. The CHIP program, which is about 4,700 kids, they have a roughly 70-30% match. So those group of kids that the services, when they get those services, the state is paying 70-30. And then we have this group, it's called childless new adult. In short, this is an expansion population under the Affordable Care Act. This is roughly 47,000 childless adults. This had to do with a group that was uninsured at the time, and the Obama administration or the federal government was trying to expand to those folks. What had happened initially was the states that don't do a lot of programs, that are less generous, when the Affordable Care Act first passed, those folks were getting 100% federal match on this population of folks. We were getting 80-20. So states that weren't doing anything were getting 100%. The states that were doing stuff were only getting 80-20. And then over the years, everybody worked close to 90-10, and it's 90-10 for this particular group. So for the folks that have expenditures that fall into this group, that's why I said in the top, you'd see Green Mountain Care and Medicaid, but underneath we have all these different buckets that people are sort of placed into, and we get various federal matches for those particular programs, and we have to report those to the Fed. There's a lot of stuff that happens on the back end. This is part of that back end calculation. But in short, this just shows you that we have various federal matches for various programs.
Joe and then Alyssa.
I'm just wondering what the definition of new adult is.
So the new adult is basically, it's a group of folks that are around 137% of federal poverty. I couldn't get in, I don't know the exact definition, but it's a group that this is a group that traditionally wouldn't be on Medicaid. They are adults that don't have kids that meet certain, I can look it up. I couldn't give you the exact. And actually what I'll tell you is in a few weeks, you're going to get the Medicaid budget book. The Medicaid budget book is like the Bible. It's an encyclopedia. It has everything you ever want to know about anything. It'll have those definitions in there. It's a very useful resource. But off the top of my head, I couldn't tell you the specific eligibility criteria for new adults.
Alyssa.
Just regarding the CHIP. So it's only 4,700 kids are
under that program for that particular criteria.
Like 40,000 kids insured under Medicaid?
There's a higher number of kids totally insured.
So
this is a subset of kids that are insured because
federal poverty level?
It's a combination. There's a specific definition. I want to say it has to do with a level of underinsurance, under 100% of federal poverty. It has to do with, I can't remember off the top of my head, but it's a subset of that group that would not have potentially been eligible for Medicaid, but I don't know off the top of my head the difference. Again, I'll look it up.
But only like 10% of our kids qualify.
A small group of our kids. It's like, I forget the number of kids we have in the program, 20 to 40,000. And that CHIP designation is only a small number of those kids.
Okay, so, and the rest of them are going under
the rest of them are going to get FMAP. Again, these are the base rates, and then we're getting 6.2 additional on top of that. So I have to just sort of flag that.
I mean, additional on the CHIP side and
on all of them.
On each,
so the
CHIP,
CHIP,
each level.
Yeah, well, so with the federal, it's straight. You just add or subtract 6.2%. With the CHIP and the childless adults, it's tied into a formula. So it's not a straight 6.2% because the formulas are determined on, at least with CHIP, it's a formula that gets there. And so it's calculated into that formula. So there is a reduction, but it's not a clean 6.2%. And actually the 6.2%, I believe, does not include the childless adults. I think they're just straight 90-10. So in a sense, it's everybody on the regular FMAP, nuanced or calculated within CHIP, and doesn't affect the 90-10, as far as if I recall. I do have another slide somewhere. I don't have it on this. I have it on another presentation I'll give you during the week that shows a cyclical cycle of FMAP. And, you know, it's a calculation. So every year the Fed tells us this is what your FMAP is going to be the next year. Sometimes it moves in our direction where our FMAP will increase, which means our state dollar decrease. Sometimes it comes in and our FMAP has decreased, which means our state dollars increase, which means it's a budget pressure. So it's a pressure that comes in that suddenly we have to pay this money without any changes whatsoever. It's just an additional pressure so we're always praying that it moves in our favor. Now, the flip side is if our FMAP is going down, it means our per capita has theoretically gone up. So it's kind of a good thing and a bad thing, right? It's a double-edged sword. It means that we're doing better per capita relative to the rest of the country, but we have to pay for it.
I was just gonna say, and if you have a hard stop, this might be a good break.
Shoot, I do. I do have a hard stop.
Yeah.
It's a perfect place to stop. Because all I had, and actually the last slides were just regulators, so we didn't even have to get into that.
Okay. Yeah, because we'll have Vermont Care Board.
Yeah.
And DFR and everyone in at this point. So thank you, Nolan.
Yeah, sorry.
There will probably be questions after, but like I said, Nolan has offered his time and he'll be back in front of us as well.
Yeah, you can email me. Let me stop share.
I'm gonna say we can go